and we've extensively researched as to what we could do in order to prevent the spread, or at least reduce the transmission of this virus. And we've presented it in the Journal of Clinical Orthodontics to the best that we could. I would really encourage all of you to have a read through, and this would definitely benefit us in the future, how to partake with orthodontic treatment and dental treatment in journalists in general as such. So this is my family and friends, because and these are the people due to which I do what I do the best. Let me just begin with a very wonderful saying. Human knowledge is always frail and subject to revision. That should make us more humble and exceedingly careful in claiming neither too much nor too little. So that's exactly why we need to be humble in our field. And orthodontics is one of the most complicated specialties in dentistry. And we have a particular learning curve, which can be very, very clearly demonstrated by this particular curve, which is the Dunning-Kruger Effect. As you can see in the very beginning, as residents or as just graduates, we feel that we know a lot of things, and I especially felt that I knew everything. I could treat almost any particular case, and then is when I started making mistakes, and the mistakes got serious. Some were serious, some weren't very serious, and that's exactly why I have this presentation for Iatrogenics in orthodontics. Anyways, so I consider myself somewhere over here at the lowest point of the graph. I'm learning, and now I'm going up, and now I'm more confident about what I do. So I have taken the liberty to classify orthodontic screw-ups, is what I call it. It's just another term for iatrogenics, as diagnostic screw-ups, mechanical screw-ups. They come under the technical screw-up category, and non-technical screw-ups, which are flippant attitude or very careless attitude related screw-ups, overconfidence related screw-ups, and social media based screw-ups. The last one, especially the social media based screw-ups, is very, very popular these days because of a lot of people posting great cases, especially on Facebook, and we tend to incorporate those things in our cases without the understanding of the biology of the patient. You see, mechanics are reproducible, of course they are, but then we miss out on the fact that there are many other factors, there are many other variables which come into contact apart from just the mechanics aspect of it. And that's exactly why many mechanics are not reproducible in all cases. And I'm a very good example of that. I'm going to be showing you a lot of cases. Many of you would have seen most of my cases on Facebook or in other webinars. But then again, it's always going to be a learning experience to see those cases. And every case has some of the other experience out of it. So I believe that this particular course of Charles Tweed International Foundation that I attended in last year was the background and the basics and the basis of how I changed my entire outlook towards orthodontics, especially when it came to diagnosis. People have a misconception that, oh, Tweed means a lot of wire bending and loops. It's not about the wire bending, or it's not about the loops. It's more about the diagnosis aspect of how we see a particular case. So getting on to the topic, considering the entirety of the related science, art, and practice, orthodontics is an extraordinarily complex form of treatment. Behrens, who's also the editor-in-chief of the AJOTO as of now, has defined orthodontics in one of his editorials in the AJOTO, I think from '96, as something induced unintentionally by the treatment. Of course, nobody wants to create an issue. The practicing orthodontist or the dentist would have unintentionally done something, used some mechanics, or diagnosed the case poorly, which would have resulted in some kind of a side effect which is negative and which is detrimental to the treatment. And that is basically the whole idea behind iatrogenics. Everybody makes mistakes. I mean, it's a lie if someone comes and says that, oh, I don't really make mistakes in ortho. Anybody would make a mistake. Anybody would have cases going upside down, creating roller coaster effects, probably pushing out the bone roots too much out of the bone. Third order problems. You see the lateral incisors getting overtalked palatally or labially. So all these are very, very common issues. Most importantly, we must know how to correct them. Just creating a problem and then saying that, sorry, boss, I don't know what to do with it, is not the solution. You must know how to properly get it back into track. And that's exactly what setting it right means. So the first kind of problem that I'm going to be talking about is extraction versus non-extraction. So this is basically more of a diagnostic dilemma. So many of the people these days, I for that matter, till 2018 used to make a lot of mistakes. I used to get very influenced by social media, especially when I used to see those great cases by mostly, I think, Spanish orthodontists on Instagram and or all these social media websites, doing all these complicated cases so wonderfully well, non-extraction by just using those passive self-ligation brackets. Then I was like, why am I not able to emulate those things in my patients? And I used to make mistakes. I really made a lot of mistakes. But then I realized after the tweet course that um, that's a terrible mistake to make. Diagnosis is the key to orthodontic treatment. And if your diagnosis is straight, your treatment becomes very simple. If your diagnosis is not right, your treatment becomes complicated unnecessarily, and you tend to create a lot of iatrogenic issues. Again, so this was me probably 2 years back, or maybe. I mean, of course, this was too much. But anyways, I mean, there are many people who would make this kind of a mistake. They would say that I'm very sure about this one. It's definitely a non-extraction case, probably because, see, you can see a lot of buccal corridor, and moreover, the nasolabial angle is obtuse. You see, so it's a very, very clear issue that oh, you need to make it a little acute, and then probably expansion would be the key to the solution in this particular case. And moreover, I'd seen a very similar case on Facebook posted maybe yesterday. Did done a non-extraction. Probably I'm going to give it a try. What we don't understand is that the biology of the patient is absolutely different. The amount of bone coverage is different. The amount of periodontal issues are different. The amount of gingival biotype is different. And there are many factors which come into play when you decide a treatment plan. It's just not the crowding, or it's not the teeth position. It's the entire the skeleton that plays a role in this. So coming out of this, I'm going to be showing you most of my mistakes in this particular presentation. Now, this was, by the way, my HR manager of my hospital, and he came in and said that, doctor, please, you're a big man over here, and I want you to treat me. And I was so naive at that particular point, looking at all these wonderful Damon cases being done non-extraction, that I was like, okay, this looks like a cakewalk. And this particular case had an inset lateral incisor on both sides. That's the upper, the 1-2 and the 2-2 both were inset. The 1-2 was to a extreme degree with absolutely no space between the central and the canine. And there was fair amount of crowding on the lower incisor region as well, with some amount of proclination. And I was under the impression that I was going to be able to do this non-extraction seriously, especially with just one extraction that I had planned on the 1-4, because this was a little too much. So I had it planned a 1-4 extraction, get the 1-3 back using a Miniscrew, get the 2 out. This we could just expand because I felt that the arches were narrow and V-shaped, right? Of course. So one more thing I'm going to be coming on to is that you might think that expansion is possible in almost all cases. Again, the biology is different. Just seeing that it has a V shape or it has a buccal corridor, please don't diagnose a case as an extraction or a non-extraction case. There are many variables which come into play over here. So I decided to do this just with a 1-4 extraction, and I was foolish enough to do it that way. I'm going to be showing you the progress with just a 1-4 extraction. So You see, I extracted the 1.4, I placed the mini screw, and I placed an 0.14 copper nitrile because they have expanded arch forms. So what I decided was I usually do this. I use light forces from the implant in the very beginning in order to tip the teeth and begin to move them back a little bit. Unfortunately, it was about 5 months down the lane, and I was not able to find any space between the canine and the central incisor. And I was wondering, why is the extraction space getting lesser, and why am I not having any space between the canine and the central incisor? It's pretty funny. Then is when I realized that I'm moving the midline. You see, I have engaged the lateral incisor over here. The force of the labial thrust and the lateral incisor coming out is pushing the central incisors towards the right. Along with it, the canine is going to the right. So what's happening is I'm losing this extraction space. I'm moving the midline unnecessarily, which is iatrogenic effect number one, which is an unwanted effect, right? And I'm still not gaining any space for getting this particular lateral incisor out. So it's not a winner. It's actually a problem that I'm causing, because I'm losing this extraction space and I don't have enough space for this lateral incisor to go out. And moreover, I've shifted the midline by about 3 millimeters already. And on the lower, I'm doing, I had done this for a little less of a crowding case before, which worked. And I use an open coil spring, which is slightly activated in order to just help with the expansion of the lower arch a little bit, especially the dentoalveolar uprighting of the posterior teeth, or in this particular case, gaining some space before I could engage the wire on the brackets of the lowers. After about 6 months, I realized that it's not working. There's something wrong over here. And I decided to still not extract on the left side, on the upper left side. You see, I knew that the midlines are shifting by about 4 millimeters already. And I know that there is no way that I'm just going to gain space by IPR over there to get a class 1. But still, you see, there's something that we have to throw out our egos, especially when we make mistakes, right? And it was my ego that was speaking then. I still wanted to do this case with as less as extractions as possible. And what I decided was, I told now the patient that I'm going to be extracting this 3-1, because that was predominantly not very strong. And I decided to go in for a 3-1 extraction. I mean, I could have swallowed my pride and said that I'm going to be extracting all the 4s and finishing your case just as an all-4 extraction, which any other day I would have. But then again, I thought that probably it's still possible for me to finish this case with a central incisor extraction. And then I extracted the central incisor. But then you see, over here now I've started using a segmental T-loop in order to retract the canine back. But I don't have enough space for the lateral incisors still. And what I started seeing is proclination of the lower incisors, although I had extracted one single incisor. I was not able to control the proclination at all, and the bone physiology of this particular patient probably was very, very different. And I was absolutely not able to see any kind of dentoalveolar expansion either. I had used a 14 nitile, a copper nitile with an expanded arch form for more than a year on the lower arch, and still there was absolutely no change in the arch form. And at this particular point, I decided to swallow my pride and tell the patient that I think now I will have to extract one of the premolars on the left side as well. And also I would have to now, of course, because I was losing the incisor proclination, I was losing onto the incisor proclination, and now I had to probably extract the third molars at the back on the lowers as well. And eventually you can see that I have retracted the case using loops and gained some uprighting of the lower incisors. I've placed the class 3 elastics from the upper mini screws onto the lower canines in order to upright them a bit, and all these things. And finally, I was able to reach a compromise, which was decent enough, but involved a lot of IPR as well. So you see, my pride and lack of good diagnosis costed the patient not just one premolar, but then 2 premolars and 2 third molars and 1 incisor. So it was a very simple 4-4-4-4 extraction, but then I diagnosed it wrong, especially the first ever. The mistake was a mistake in the diagnosis itself, and that's the very first step of the treatment. And I made a mistake there. So you see, that's what happened, and somehow I was able to get it back, and I reached a decent compromise. And luckily, the patient was very compliant. Of course, he was my HR manager. He couldn't have said much, but anyways, that helped to my favor. So what I want to get out of this particular case is some people just say that, oh, you have a lot of buccal corridor, or your nasolabial angle is acute or obtuse, and so you need to either go for extraction or non-extraction. But these are not the detrimental. These are not the determinants of extraction and non-extraction. There are many studies which show that just having a buccal corridor doesn't mean that you can go in for a non-extraction. It depends on the bone. It depends on the amount of bone that you have, and the physiology. I'm going to be showing you a very small example from one of the papers published in the Anglo-Orthodontists in 2008. As you can see, this particular female, there are two different females with very similar nasolabial angle morphology, and you will be surprised to see that both of them look like they're pretty non-extraction. But then you see that the underlying teeth in this are extruded and retruded, but in this particular case, they are proclined, and so you can't decide whether you would just want to extract or non-extract based on the nasolabial angle. And of course, if you do a non-extraction treatment, which is a little extreme, you would procline the lower incisors, and that's a big no. Especially expansion in the mandibular arch, intercanine width expansion is very, very unstable. Moving the mandibular incisors more than 2 millimeters can be very, very unstable due to the increase in the lip pressure, and that's going to push your teeth back, and that's going to cause a lot of that's going to cause a relapse, especially if there was crowding at the initial particular point. And you see, yeah, so basically these are the factors that are determinants. And recently, very recently, there was a wonderful, fantastic study by Matsumoto et al. Who reported that you see, there is a 50% increase in the probability of dehiscence when well-positioned incisors are proclined by 2 millimeters. So you see, or 8 degrees. So IMPA increases by 8 degrees, or the L1NB increases by 2 millimeters. You risk 50% chances of dehiscence post-retention phase. So that's a big number. That's not a joke. And that's exactly why I always say that your lower incisors must be upright. So there are no leeways here. I mean, I'm a tweed guy, and you don't get much out of a non-extraction case. So if in doubt, I would always go in for extraction, never do a non-extraction. Oh, that's the next slide. So for me, a borderline case, if in doubt, I would any day extract, because for me, managing spaces are far more easier than having no spaces and managing the case. It's a nightmare. So criteria is I would go in for a non-extraction treatment on a borderline case at times. But there are just few factors. Like, for example, if the soft tissue is very favorable, that means that if you have a very good, or if you have straight profiles, or if you have flat lips, and if you have underlying crowding, I would definitely go in for a non-extraction case strategy. Good buccal bone thickness in the posterior region, yes. Non-extraction, probably. It depends. It depends on many factors, but these are some of the factors. Lingual tipping of the lower posteriors, yes, probably they can be uprighted without the need of extractions. Upright the retroclined lower, yeah. So if you have retroclined lower incisors with crowding, beneficial till we can gain about 90 degrees to the basal bone. Good lip competency. I mean, if the lips are very competent, there are very less chances of me going in for an extraction protocol, one of the reasons again, and a favorable curve of spee. What I mean to say over here is that if you have a deep curve of spee, you might risk flapping the curve of spee and then pushing the teeth forward. So you need to make sure that your teeth your teeth are they don't have much of a deep curve of spee. Yeah. So some of the other factors that you must not consider while deciding non-extraction is that you saw a similar case on Facebook the other day. And so you want to do it non-extraction. The nasolabial angle is favorable, like I showed you in the last slide, or just because you want to please your patient and the patient says that, sorry, doctor, I don't want to go undergo extractions. Or I just want to be doing this non-extraction because I want to please the manufacturer and become a KOL someday. So these are not supposed to be your diagnostic criteria for doing a case non-extraction. Okay, so the take-home message over here is that the extraction treatments are universally good, or that non-extraction treatments are bad. It's not that they're good or they are bad, but rather that both produce favorable results for the right patient, and that extraction does not necessitate flat or long faces or narrow smiles with dark corridors. That's not the truth. And this is from a wonderful paper by a very good friend of mine, Dr. Bowman, Jay Bowman, and Dr. Lyle Johnston. So they're both legends in the field of orthodontics, and I would recommend everybody to read almost everything that they've written on. And whatever they write is excellent. So coming on to the second aspect of the diagnostic criteria are the pseudo versus true class 3s. And I believe that a lot of people have, including me, have had a lot of issues, especially in diagnosing a pseudo from a true class 3. So again, Dr. Bowman writes exclusively a lot on class 3s and pseudo class 3 corrections, and he has had many inventions, especially in this particular field. And I'm going to be showing you some of the cases. Now, this is a case which would highlight what Dr. Kleber Merilis was talking about in the previous lecture, the advances or the uses of using elastics at the right time for the right patient with the right amount of force, right? So you see, how I diagnose a pseudo class 3 from a true class 3 is very simple. I ask the patient to open his or her mouth, and if usually a pseudo class 3 is accompanied by unilateral crossbite, or at least a crossbite where there is a slight asymmetry of the jaw. And if I find that the facial midline is coinciding with the lower incisor midline on maximum mouth opening, I would term and diagnose that particular case as a pseudo class 3. Because there is a shift towards the normal when the patient opens his or her mouth. And that means to say that when he or she is closing, there is some kind of a premature contact, especially in the anteriors, which is hindering or not allowing the patient to bite in his or her centric relation. And that's the new centric occlusion, or the proposed bite, or the habitual bite, or the functional pseudo class 3 bite that she has. Similarly, you can see this particular case. If I was not very well trained to diagnose a pseudo versus a class 3, true class 3, and I have made this mistake, and that's exactly why I had this particular case over here to demonstrate iatrogenic effects. There was this once that I had diagnosed a case wrongly as a true class 3, and I ended up extracting one premolar in a very similar case. Because of course, you see there's a huge class 3 defect on the canines, and I can see a huge class 3 over here. I usually don't go in for corrections of the molars much. I more base myself on the canine guidance and on the canine relationships. I don't really mind if the molars are a class 1, class 2, or class 3, as long as they have a very good cusp-to-fossa relationship, and the temporomandibular joints are pretty well settled and placed in the fossas. So anyways, I probably had decided in that one case that I had extracted the premolars, and then when I leveled the arches, I realized that I had gotten rid of the premature contacts, and now the bite automatically shifted to the center. And now I had a midline on with a huge premolar extraction space, and I had to push the premolars all the more forward into a heavy class 3. And it was very difficult to get interdigitation in that particular case. But yeah, so I learned from that case. And from then, I never extract on a pseudo class 3 or even true class 3 for that matter, because still it can get a little confusing unless and until I have absolutely leveled the arches and gotten rid of all the premature contacts, like in this particular case. Now, what I tend to do is I raise the bite at the back teeth, a little rounded, especially on the sevens, lower sevens, and I keep them a little rounded so that when the patient occludes, he or she is not able to occlude and the bite slides. And that's exactly what I want. I want to confuse the patient. And then I simultaneously use elastics in the right ways to get the jaw shifted back. And it guides them into the right position. So you can see that this patient had increased joint spaces on the right fossa, possible distraction of the condyle. As you can see, the joint spaces over here are increased. And so what I did is I raised the bite, as I mentioned, and then I used a combination of class 2 and class 3 elastics. And you'd be surprised that in about just 4 to 5 months, I was able to get a midline on. And you were talking about a good central incisor, that's about a 6 millimeter midline shift, and automatically corrected with just elastics. And these are just 3x16 medium elastics. These are not very heavy gauge elastics. And I got a complete class 1 on both sides. And that is exactly what happens with a pseudo class 3. Easy to correct, provided you diagnose them properly. And this was the end. In just about a year or so, I was able to finish this case almost perfectly. And this is not the best. You see, if you catch hold of the pseudo class 3 in the growth before it is traversed into a full-blown true class 3 with an asymmetry, there is a good chance that you can correct it. So in this case, you can see that there is a jaw deviation to the right. As you can see, the mandibular symphysis is pointed towards the right of the face. In this picture, you can see that it's absolutely straight. And also you can see the tremendous change in the profile of the patient without extractions, with just the correction of the jaw, right? And then the best part is that you can see that the joint spaces on the right and left now are even. So that's that. Now, getting on to the next part, and that is the iatrogenic effects of time. You see, iatrogenic effects are some things that that are not just physically seen on the patient. Even extending the time of the treatment is considered an iatrogenic effect. Using unnecessary treatment objectives, goals, mechanics, or round tripping is what we call it in orthodontics, may increase the treatment time unnecessarily. So there are some cases in which you can speed them up, and this is an example of one of those cases. Now, this is a case of a very young girl. I believe she was 12 years old, and with a class 2 div 2 kind of situation, with very, very aligned lower arches, missing 2 lateral incisors in the lower arch, and good amount of crowding on the upper arch. Now, I would definitely extract, and most of you would definitely extract in this particular case. I would extract 1-4, I extracted a 2-4, and now, let me give you a hypothetical situation. You see, in such a case, what happens is you want to retract the canine back. You're going to be giving a tie back from the molars, right? What happens is when you give a tie back from the molars onto the canine, what we don't realize is that there is evidence that tie back is almost useless when it comes to retracting the canine back and aligning the incisors. It does retract or tip the canine back, but it does not align the incisors. And number 2 is that it loses anchorage. You see, mesial movement is very easy compared to distal movement. And so what happens is that the canine might tip back, but in the end, after leveling, you would realize that you've almost lost the premolar space and your canines are still in a class 2 because that was just tipping of your crown back. But the molars have moved bodily completely forward. So what I did in this particular case, and these are the papers which just show the lack of effectiveness of tiebacks. I'm going to be rushing through it because I don't have much time and I have a lot of cases to show you. So I placed an implant at the back, and this you can see is an 014 NITI. Now people would be a little shocked with the use of a power chain on an 014 NITI, but yes, I do that sometimes. Now there is a reason behind it. You see that a NITI has engaged into all the teeth in the front, and I've run loose ligature tie from the canine to the canine. Now the loose ligature tie is to give it still room to alleviate the crowding, and I've used a power chain with just about 50 grams of force from the Miniscrew onto the canine. So what this does is it doesn't retract the canine, but it gives a sense of direction to the canine to go back into the extraction space and simultaneously alleviate the crowding. Now, how do you know that I haven't fled the teeth? Because if conventionally I would have put a night tie or just a tie back, I would have increased the overjet, then I would have retracted. And that is exactly what is called round tripping, and that I would spend time on. Now you see that I haven't bonded the lower teeth because they're fairly straight, and I have the same overjet here as well. So that gives me confidence that I haven't flared the upper teeth at all, and I've moved the canine back in the extraction space. And surprisingly, in 3 months, I had closed almost 50% of the extraction space. Once the arches were leveled, I immediately jumped onto a 1725 with a curve of SPI because the arches were dumping a little bit. So I put a curve of SPI on the wire like this. It's a accentuated curve of SPI, and I retracted. So that intruded as well as gave a forward or a clockwise vector on the incisors. And jumping on to the end immediately, 1925 NITI. I usually finish my cases on a 1925 NITI with some settling elastics. So basically the point is that I started to retract earlier on, and you can't do this on a very well-leveled arch, because if it's a well-leveled arch, your teeth are going to dump. Now, just because there was a good forward thrust on these incisors, I was able to balance them using the retractive force of the power chain. So this is the result in just about a year, and it's an extraction case done in a year without much waste of time. So I would definitely call it successfully overcoming the iatrogenic effects of round tripping. So yeah, so with some growth as well. Now let me just get on to some cases of ectopically positioned teeth. They cause a lot of iatrogenic effects, especially high canines, because I always consider them ankylosed while pulling them down, or else they tend to pull the entire arch up when we level. So sectional mechanics is the best possible way to do it. Now, I have devised a few ways of doing it. I usually, for buccal impactions, I expose the canine, I place a bracket, I bend a 1725 or an 1825 stainless steel, put some flow composite over here to lock it, and then I use a crimpable hook, and I place a mini screw on the opposing arch, and I give 1/8 medium elastics. And it works pretty well because I have not contacted the entirety of the other arch. So there is absolutely no issue of reciprocal forces or iatrogenics that are possibly happening. You might ask if interrupted forces or intermittent forces are enough to generate forces to get the canine down. Well, yes, it is. This delivers about 150 grams of force, and if you want to read more of it, you can take a screenshot of this paper, Intra-Arch Traction for Impacted Canines, which has been published in the APOS Trends in Orthodontics for the details. And this is a pretty interesting way of getting canines out, especially buccal canines. Now that's about buccal. Let's talk about some palatal canines. You see, you can see over here in this young lady, you can see that the horizontal impaction of the canine, and it's in a very awkward position. I'll show you the CBCT. You see, this is poor prognosis canines, because it's higher, that the apex of the root is higher than that of the premolars, and it's somewhere between the central incisors, the crown tip, and it's an angulation of more than 30 degrees, in which, according to Cunningham, is considered poor prognosis of canines. And I would come into this category, as you can see over here, in the third category of poor prognosis. Now, so what I decided was pretty much the same thing that I did in that. So this is a schematic graphic. So I placed a button on the impacted canine after exposing it, and I used the same power arm as you can see in my previous paper, and a buccal shell, a mini screw on the lower arch, and you can see the maxillary elastics. So this is the kind of hook that I bent on the lingual button, which was affixed onto the surface of the canine, as you can see over here. And you can see the elastics 1/8 again, which is hooked onto the mini screw outside. And gradually you can see how the canine has wonderfully just come out. Yes, of course, it needed some derotation when it came out because it's absolutely rotated. And you can see it's into the arch. So you can see the position of the canine well aligned over here. This paper is already accepted, and it's going to be published in the November issue of the Journal of the Contemporary Dental Practice, titled Inter-Arch Traction Strategy for Palatal Cuspid Impactions. You can take a picture of this. You can give it a read. Now, very common issues, especially come in when in terms of third order issues of canines or lateral incisors impacted, or inset lateral incisors. When we get them out, we see that the crown is too forward and the root is too behind, and we need to correct third order issue by incorporating torque. And it's been proved that extra slot mechanics of this sort, using a Goodman spring or a Warren spring, is more beneficial than intra-slot method. So now we have modified this particular torquing spring to a very interesting thing. Now, I'm sure that you can't appreciate it, but let me just tell you that this canine is absolutely out of the bone. The roots are absolutely out of the bone, and there was no way. And now you see, all these Goodman spring or other kinds of springs can be used comfortably only if the teeth are very well aligned, because you need to use a base arch wire, and then you can use the torquing spring. But what if your arches are not aligned? You can't incorporate those springs on a light wire, right? So you need to have some kind of a segment, and this is the segment that I'm talking about. You won't be able to understand it over here. Probably this is a little confusing. I placed a buccal tube vertically on the canine, and I'm going to be showing you this animation. So you see, this is the wire that goes from the auxiliary tube, and it's actually with a helix and going up. And then I twist it like this, and I push it inside the buccal tube. So the wire wants to come out like this, right? Because I twisted like this, so it wants to come out like this, and that's exactly how it'll push the root in. You see, like, and then you push it in, and I'm going to be showing you a video of this so that it's very, very clear. So this is inactive, passive, affixed to the buccal tube, and I use a wine guard, twist it inside, because you see this root is out, right? So I need to push it in, and then I push it into the buccal tube. So it's going to try to come out, and that's going to push the root back inside. Modification of the Hugo spring. Now, next, a very interesting case of complicated high canines with a little untoward angulation of the canines. These are very tough angulations, especially because you have distally tipped, and the root is way inside, the crown is way outside. So it has issues in all three planes and just not the vertical. And moreover, she had a lot of bone periodontal issues. Iatrogenic effects are from the very beginning seen in this particular case. You can see that I placed a Miniscrew, did the right extractions, decided to move the canine back using just a power chain on the bracket, because I thought that it's rotated mesially and it would rotate distally. Unfortunately, because I was nowhere close to the center of resistance, that did not happen. And then I was not able to see much of an effect. So what I decided was I'm going to be using a little power arm from the bracket going up to the center of resistance, and then I'm going to put it more horizontally. But again, because I was nowhere close to the center of resistance and the root was very long, all I did was I tipped the canine further in, which pushed the root out, as you can see over here. Now, at this particular point, I got scared, and I was like, enough of this fancy mechanics. I might as well go back to the conventional overlay and upright it. But then, the more I did this, the more the root came out, and the root was almost 100% out. You can see the apex as well. Now, most of the clinicians would just extract this particular canine and apologize to the patient. But then what I decided was I would just wait it out. I decided to remove the brackets from this premolar as well, use an open coil spring on from this molar tube onto the central incisor, relieving the pressure on all the three teeth, creating some space between the premolars and the lateral incisors, and letting this physiologically relapse in. As you can see, after 3 months of doing that, the root prominence got better. And once after 3 months, I found that the root had already comfortably gone in. I put in a 014 NITI with very light forces, began to settle. And finally, I put in a 21/25 to get the torque right. So 8 months after the reapplication of forces, it's like this. And this is prior to the gingivectomy, and this is post-gingivectomy. She got a good smile, and I was able to get that absolutely poor prognosis canine with full of dehiscence into the bone back by just the physiological correction. And if you want to read a lot about this paper in detail, you can go in. It's published in Case Reports in Dentistry, and this is the PubMed screenshot. You can just take it, and it's titled Physiological Mid-Treatment Tooth Movement as a Correction Strategy for Iatrogenic Root Exposure. So now, next, I would just skim through a case of mine in which the iatrogenic effects usually are caused by inappropriate diagnosis of curve of speed. So you see, especially on high angle cases, it's very important to, or low angle cases, it's very important to know how are you going to correct the curve of speed. Now, studies have suggested that, especially through papers of Rosie et al., they suggest that on a high angle, the usual curve of speed on the lower is corrected by extrusion of premolars, and that's not what you want because it makes the angle higher. It's going to throw back the mandible further backward, and that's not what you want. But then that's unfortunately what happens because the muscles are very loose and lax in high angles, and not so in brachycephalic or in low angle cases where the masseters or the muscles are very strong. And they don't let the eruption of the posteriors, whereas they procline teeth in order to correct the curve of speed. Similarly, in this particular case, she was a 40-year-old case with the knife edge bone on both molars, missing molars over here because there were long-standing extraction cases. So what I decided was, because it was high angle, there are 3 strategies that I use. You see, I don't want the molars to extrude. So number 1, I put in the bite turbos. Number 2, I want the anteriors to intrude in order to flatten the curve speed. So I use something called high pull mechanics. That high pull mechanics are basically nothing but the miniscrew, which are placed a little higher than normal in between the premolar region so that the forces are more vertical than horizontal. And they give you an intrusive component while retraction. And also, you see, I wanted to close the space on a knife edge because the patient had particularly mentioned that she's not going to go in for any kind of implant or any of that sort. So I had to somehow close. And I had read a few papers by Dr. Bertie Melson, who suggested that I need to somehow get the molars upright, distally tipped, so that the roots move forward first and then the crown goes forward. So I decided to place in a gable mend right distal to the premolars over here, something like this, tip the canine, rotate it back and molar and get the roots forward and then close the spaces. So this is the hypermechanics. And you can see that I was able to get the molars absolutely 100% in the knife edge bone and protract them. A very difficult case, especially in a 40-year-old adult. But then you can see that the molars are almost distally tipped, and usually you would see a mesial dumping of the molars, but in this case you can see that they're very well upright. And you see that there is no coverage on the second molars, but we have the vacuum formed retainers, and we had a pontic placed over there because there's no space enough for an implant to be placed over there. So I'm just going to be jumping on to some of the cases, especially which would show the iatrogenic effects of because I think Dr. Akram, I think I have 5 minutes more, right?
Yeah, we have 15 minutes more.
Oh, you have 15
questions and answers, yes.
Okay, then I don't need to hurry up that much.
About 10 minutes.
Yeah,
10 minutes.
Fine.
All right. So now the next session that I'm going to be going into is that of the roller coasters. And you see, please don't mind the pictures because I've taken this from the paper, because we lost all the records of this particular patient. And you can see that this is a pretty simple case of just upper probably premolar extractions and correction of the bite in the class 2 in this particular case. But then when I received this particular case, it was iatrogenically dumped. You see that I don't have enough overjet to retract into this extraction space. And you can see anterior dental extrusion because the wire is a 16 by 22 stainless steel. And that wire is not stable enough, and there is no curves beyond the wire. And so what's happening is there is a relative extrusion of the entire anterior segment, which is dumping down. And I have a deep bite. I have retroclined incisors, and I have an entire premolar space to close. And the patient is sitting on top of my head because she wants to get the braces off in about 9 months' time from now, probably because she was leaving the country. So I had to devise a plan, and what I did was I strategically modified the intrusion arch, the one-piece intrusion arch from the molar to an implant, and I placed in a 17 by 25 TMA wire over here. The key over here is that the left side implant needs to be a left-hand mini screw, or else it's going to unwind. So when you activate this particular intrusion arch, so I cinched it back and I activated it, and then I pushed it down, tied it at 3 different particular points at the incisors in order to get reciprocal intrusion. And you can see that over a period of about 4 to 5 months, I was able to intrude the incisors. You can see the clinical crown becoming less. And you can also see that the spaces have closed. Now that's because I started to retract with the power chain simultaneously. What's important is that you will find excess coming out from the intrusion arch, and you'll have to keep cutting it and cinching it back almost every month. And probably towards the end of about 8 or 9 months, I was able to finish the case and close all the spaces. You can read the details of this particular case in one of my papers published in IJO titled Mini Implant Supported AVG Intrusion Arch. So the next case that I would like to be talking about is this particular case. Yeah. So now this is one of my favorite cases of a young lady, and this case has a lot to do with what Dr. Flavia has been speaking in her lecture. As you can see, that this is the incisal display at rest, and this is the amount of gummy smile that she has when she smiles, and this is a lot, and a typical incompetent lip and a heavy bimaxillary protrusion that she had. So this is the case, and this is an orthodontist's delight. I mean, you get a case like this, you would love to treat it. You can see the amount of proclination. You can see incisor proclination. You can see the gummy smile. You can see the deep bite. You can see a class 2 occlusion. You can see narrow arches, upper and lowers. Now, unfortunately, when I received the particular case, this is the pre-records that I got from the previous dentist. So what was happening was they extracted the 4 premolars, and they somehow retracted the canine without any anchorage. So what happened is the canines are still in a class 2, which means that all the anchorage had been lost. And the wire is a 16 niti, and some kind of loops were placed in the lowers on a 16 stainless steel with implants at the back. But then the bite had deepened all the more. And then in the second stage, I think the segments were formed with very short hooks, and implants interradicular were placed distal to the molar. You can see a huge step, especially over here in the second and the first. And they were retracting it. So what happened is, because these hooks are very short, they are not near the center of resistance of the anteriors. And so what happened is they dumped the incisor segment further down. And unfortunately, 90 or 80% deep bite turned out to become 100% deep bite. So what happened is, I think I received the case at this particular stage, and I decided to close the space anyways. I was like, I can't do anything with this space. So I decided to just put a power chain, close it, get it, and correct the case in a different way. So once the spaces are closed, I devised an entire strategy. And this is what happened. You see, the mini screw had pulled the incisors downward and backward and extruded them, dumped them further. Now, what I decided was, I decided to change the implants to infrazygomatic implants, IZCs, and I placed an extra 2 screws in the center to intrude them as well. You can see this. So what I decided was I changed the position of this particular screw as infrazygomatic, and I placed 2 additional screws over here between the lateral and the central incisors, and I decided to impact the entire maxilla with it. And you can see that the distalization with the intrusion has got me into a class 1 occlusion and has reduced the clinical size of the crown considerably in order to correct the gummy smile. Now this was at the end of the treatment, when you can see a lot of gum, and that's because of the intrusion component, and she needed heavy contouring. And after contouring, you can see the change in the profile. So you can see the amount of proclination that has been controlled, and you can see the amount of dental movements through the superimpositions, and you can see a wonderful change in her smile from the before to the after. So, and even the bimaxillary protrusion has been corrected. You can access this particular paper, which has been recently published in International Orthodontics, under the title "Treating a Severe Iatrogenic Gingival Exposure and Lip Incompetence Challenge Worthwhile." It was indeed a challenge worthwhile.